All right, now on to confirmation tests and the utility of different tests listed here, and uh, repeated motions coming up first, or centralization. So remember talking about this with active range of motion. So you might even be doing this at the time of your quarter screen. However, it's placed here in our exam as it's best for confirmation. So that being said, look at our positive likelihood ratio being nice there, 6.7. Also some utility for screening purposes as well. But if we see that peripheralization or centralization of symptoms as the patient goes through repeated flexion or repeated extension or repeated rotation to the right or left or repeated lateral flexion, that can aid in identifying radicular symptoms. Now, that being said, it was studied in the context of discogenic symptoms, but essentially, you'll see some variation in how radicular symptoms have been studied. Now, our well leg raise test, let's go ahead and have a look at that real quick.
Now the well leg raise test. We're going to have our patient have symptoms on the left side this time. So we're raising the non-symptomatic lower extremity and looking for provocation of symptoms on that symptomatic side. So I'm raising the patient's right leg, looking for provocation of left lower extremity symptoms, radicular symptoms, that is. So let me know as soon as you feel any of your symptoms come on. As soon as those symptoms come on the left side there, that's our positive test.
And if they don't have concordant symptoms reproduced, that'll be a negative test. So again, note our nice positive likelihood ratio, though it's notable that our quality of study was not that great for this. Now, our femoral nerve tension test, essentially with this, we're going to have the patient in prone. It helps to put the patient down in a position of neck flexion to start with, and you can do that by lowering the head of the table there. Now, there aren't really any studies that have investigated research properties for this, but that being said, it can be something that you use. It could be helpful with a femoral nerve entrapment or a higher radiculopathy, radicular pain. A higher level, that is. Again, patient in prone here, we're going to start by bending the patient's knee. Now, it can be helpful to palpate that PSIS as you're doing this, as if you feel any motion in that pelvis, that could be related to a tight rectus femoris, kind of like with Eli's test, essentially. So we want to palpate to the point where we start to feel pelvic movement, and if we do feel any pelvic movement, we want to stop that component of the test. Now, what we can do if the patient is not experiencing any symptoms at that point, we can go on what we see in the right side here, the right picture. So extend the hip a little bit. Once the patient's symptoms are provoked, radicular symptoms that is, we can have the patient lift the head up to neutral, thereby relieving symptoms in theory. So essentially any change in symptoms in the lower extremities with change in position of the neck for this. Now, our CPA or spring testing, we've talked about that. We looked at a video of that already, but essentially, again, pointing out the greater utility of this as a confirmation of segmental dysfunction. So not the greatest, as we saw with that study when we were talking about joint mobility testing, not the greatest for finding hyper or hypomobility, but a better test for finding our symptom provocation at a given segment or at an affected segment. Our instability catch sign we also talked about in range of motion testing, but essentially a hitch in the patient's giddy up. So as they're coming back to an upright position from a flexed position, if there's a little pause and it's not a smooth motion that occurs, not the greatest association with this, but this would also be considered an aberrant movement pattern like we see with our clinical practice guidelines. Now, the passive lumbar extension test, I didn't make a video of this test. It's fairly straightforward here. Essentially, the patient's in prone, and we, with the patient nice and passive, we lift the legs up. 30 centimeters is what's described here, but lift them up off the table. And symptoms being provoked would be our positive test, pain in the back. And that would be positive for neuromuscular instability. Now, the prone instability test, let's go ahead and take a look at a video of that. But I'll tell you off the start here, I had some problems with the video. And I'll come back to this and start explaining in a second.
Now, the prone instability test. This.
Make sure I'm sharing here. Yep.
The test for neuromuscular instability.
My dog is surprisingly into this.
That being said, in the clinic, hopefully you'll have access to high-low tables. The table can go up or down. You'd ideally want your table to be just below waist height for your patient. You're going to have them get in a modified prone position here with the legs off the edge of the table. They can hold on to the table if they want. Now, as we're going through our PA assessments, if we find a symptomatic segment here, we're going to stay right on that segment. We're going to ask our patient, is this producing your symptoms? Yes or no. If yes, we're going to ask the patient to lift the legs up off the ground. Now, when we have them lift, we let off the pressure, but we keep our hand right where it is. So we're not maintaining the pressure so much as maintaining the same segment or same position. So go ahead and lift.
And that's where the video started having problems there. So let's switch back here. All right, so as you can see here in our bottom right picture, the patient lifts the legs up and we re-administer that PA. So we've done it with their legs resting, with the back at rest, and our second time we're doing it with the legs extended actively, so they're up off the floor. Now, a positive test is going to be reproduction of the patient's pain when they're passive, like in the top left picture, but no pain when we do our PA once the patient has lifted their legs, like the bottom right picture here. So essentially, we can think about it from a theory perspective, and with the bottom right picture, when the legs are raised, the patient is engaging their lumbar musculature, so it makes it harder to get any excessive motion when we do our PA. So that being less painful with that, we know that we're not being able to reproduce their symptoms, as we're not able to provoke the pain when they don't let us move that segment as well. So in other words, when they're engaging their lumbar musculature much more so. Now, this has poor research properties, but note clinical implications with this. It's a component of our treatment-based classification system, a positive test for this, which would help us identify a classification for patients. Now, I do want to note also that this test is described in different ways, such as maintaining the pressure as the patient lifts the legs. But that being said, I would recommend where we actually let off of that pressure as they're raising their legs.